Welcome everyone. Thank you for joining us for this Tuesday lunch with RITA and EUVAS webinar. The topic will be long-term quality of life in patients with vasculitis. And we have two wonderful speakers today. First of all, I would like to shortly introduce myself. I'm Charlotte Velde-Keizer and I'm a nephrologist in the University Medical Center Groningen in the Netherlands, and also member of the Vasculitis Center in Groningen. Please do use the chat function we have. Please let us know where you are joining us from. And we would really like today to be an interactive session. So please do use this question tab, which you can find on the right-hand side of your screen, to ask questions anytime during the presentation. And at the end of the second talk, we will have a Q&A. So all your questions will be discussed. So as I already mentioned, we have the pleasure to welcome two talented speakers, and I would like to start with introducing the first one. First, we will hear Julie Power. She was diagnosed with ANCA-associated vasculitis in 2005, and she founded Vasculitis Ireland Awareness in 2010. She is passionate about improving the lives of those living with vasculitis, shortening the diagnostic journey, and raising awareness. She has a EUPATI fellowship. She's a board member of Vasculitis International, and she's currently the vasculitis patient representative lead in the ERN-RITA. She's also involved as a researcher in several European-wide research projects. Julie, the screen is yours.
Thank you very much for that introduction. I just hope I can manage the sharing business okay. Oh, I've lost it. Right. Sorry about that. So I am Julie Power. I have lost my presentation. Sorry. Oh, sorry about this. There we go. There we go. Okay, can you see my screen? Charlotte, can you tell me if you can see my screen?
Yes, yeah. We can see your screen.
Okay. So I'm basically going to talk very much about the long-term quality of life in patients living with vasculitis from a patient perspective. So as we all know, like whenever you're diagnosed, there's so many changes that happen in your life. And I think this piece of artwork by Shanali Pereira really depicts what it's like whenever you're first diagnosed with vasculitis. Your whole body is reacting. So there's loads of physical changes. So you have pain, swelling, there's organ damage, and an awful lot of symptoms to be dealing with, fatigue. There's also a lot of psychological damage, but the thing is that only comes in after the drama of the diagnosis. So once, like the life-threatening side eases, once we're on an even keel, it's very often we end up having anxiety, depression, and it's all very natural. It's a very normal process. I believe we go into a grieving process for the life that we lost, and I think it's very natural, and it's something that we have to go through. So don't be afraid to ask for help. Don't be afraid to talk about it. Go to your GP, go to support networks, and often, taking medication to help you get over that bump is really good. There's also a lot of changes in our relationships. We are dealing with lots of different symptoms that this is a rare condition. A lot of the symptoms are very strange. They don't seem to match up. So it's very hard to understand even the names of the conditions whenever somebody asks you, like what's wrong with you. If I was to say, oh, I have granulomatosis with polyangiitis vasculitis, well, I know they're switching off before I've even finished the first word. So it's very hard for people to understand what it's like living with vasculitis. And that's not just your friends, it's your family, it's your partner. And often, you try to protect your family, or you try to protect those that you love. You don't want to be seen to be the one that's dependent or that. So it's really important to keep, lines of communication open. There's also going to be difficulties with being intimate, things with, like with pain, fatigue, and it's very hard to understand that as a partner. And I think one area that's often forgotten is that in females, because we're put on chemotherapy, sometimes, like to treat the vasculitis, we're put into early menopause. And because you're not expecting to go into menopause at that age, um, everything is put down to vasculitis. And really, we need to be treated for going through the menopause. Um, and there's a lot of physical changes that happen that are very personal. And I think it's important to be able to talk about that and get help for that. Our lifestyle changes. Some of us, we're able to stay and work. Some people, like myself, I had to medically retire because I had to make the decision. I wanted the life with my family rather than my career. I didn't have energy for both. So our lifestyle changes, and then our future has changed. The plans that we would have had, are all completely changed. So there's an awful lot of change that's going on that we need to accept. The main priorities whenever you're into your journey of vasculitis would be to access a specialist centre. So either attending them directly, or that your consultant is in communication with a specialist centre. The world of vasculitis is changing so quickly. There are new guidelines coming along, and they're all very different for each of the different types of vasculitis. We're getting more directed in our treatment of vasculitis. So it's really important that we are being seen or overseen by somebody that's well experienced in the world of vasculitis. When you're diagnosed with something that is rare, you've even been told it's rare, you just automatically feel very isolated. So it's really important to talk to other people that are living with vasculitis. It's really important to get your information from reliable sources. The internet is a great thing. Dr. Google is there all the time, but it's really important to get the reliable sources to get the good information. Talk to your healthcare team about how the vasculitis and the treatments are affecting your quality of life. Very often we go to our appointments and we talk about our symptoms. And it's hard for the healthcare team to understand how those symptoms affect our quality of life, because they're not waking up in the morning with this, so we need to be very open with our healthcare team and about our priorities and what we want. And just to re-emphasize that, as getting into remission doesn't happen by just taking the medication. It's a lot of teamwork. So I saw this cartoon thing yesterday, and I thought it was very funny because this is me on a bad day. I've decided my body is not a temple, it's a haunted house. It's slowly falling apart, makes weird noises, and contains the spirit of an old lady who's always mad at something. But really, my everyday is that I have finally accepted that I am living with vasculitis. I have vasculitis, but it doesn't have me. I have some control over it. So, learning to live with vasculitis, the big thing is to listen to your body. Your body is the only tool that you have that's with you all the time. When you go to sleep, when you wake up, it's experiencing all the symptoms, everything. So listen to your body and acknowledge these symptoms, these strange symptoms, and act, especially when you have vasculitis. and you have been through that whole diagnostic thing, if you start to notice little signs that things are not quite right, act. Go and find out if it's a vasculitis, or it might be something else. Your body doesn't do things just for the sake of it. There's always a reason. Ask questions. Don't just. It's very hard with a rare disease to take on board all the information that is coming at you. I think there's been research, and they say that you'd come away with about a third of what you've been told in an appointment. But ask questions. Ask your healthcare team. Ask support groups. We have in Vasculitis Ireland Awareness, we've recently started a chatbot, a Dwayne bot, that's based on reliable sources from other vasculitis associations. But it's a very safe way to ask questions that you might feel silly about asking, but no question is silly. And it's really important to inform yourself about the vasculitis and about the treatments. So recognize triggers and changes in your quality of life or the symptoms. So there'll be things like stress or infection or exposure to environmental factors, reaction to drugs. Take a note of all these. It's really important that we start recording this type of data to help us manage our conditions. And like the old way is with writing, and it's very concrete way, but more and more we're using apps out there. We're using Fitbits, we're using healthcare apps, and it's really important to be able to keep a record of this data, because then we can start seeing patterns of what is triggering our symptoms or triggering our vasculitis or triggering something else. But the whole world of apps and AI is a very tricky world. So in one of the projects that I'm involved in, Paradise, I have the link here, and if any of you are living with vasculitis, I would really appreciate if you could go to that link and fill out the survey about your perception of using AI in healthcare. This project, we are looking at trying to personalise medicine so that we're not staying on medications for too long. But we need to find out, are people happy with AI being used in the healthcare? It's also important to share with our healthcare teams and researchers so that they can learn more about vasculitis too. And this is what we call like patient-reported outcome measures and patient-reported experience measures. And I'm going to leave that all to Jo to explain that to you. But these types of information are so important. In the future, progress is always happening. We're an important part of the team. And we need to do our bit as well. So for us to find out more about vasculitis, we need registries to find out the numbers that we're dealing with, the types of vasculitis that we're dealing with, the types of medication that's being used. We need biobanks to gather all the samples. But if we have these two things and the patient-reported outcome measures, we will learn so much more about vasculitis, about the causes, the flares, the effective personalised treatments. This will lead to more empowered patients, and it will lead to informed, meaningful research. With teamwork, a good quality of life is possible. I'm living with vasculitis for 20 years. I haven't had the life that I, had thought I would have had, but I've had a very good life. There's always a way around a problem, and a good quality of life is very possible. So with that, I thank you very much for the opportunity to talk to you here today, and I welcome any questions. I'll try to get out of this now.
Thank you, Julie, for sharing your experience with us. So as Julie already mentioned, please do ask your questions in the Q&A, and at the end of the next talk, we will discuss the questions for Julie. And now I would like to go on with the second talk of the day, and this will be given by Dr. Jo Robson. And Jo is an associate professor in rheumatology working in Bristol in the UK. With a research and clinical interest in vasculitis, specifically ANCA-associated vasculitis and giant cell arthritis. Her research interests are in the development of these patient-reported outcome measures, these PROMs that we heard about, and health-related quality of life. She leads the international development of the PROM for ANCA-associated vasculitis, which is called the AAV-PRO. A PROM for patients with giant cell arthritis, which is called the GCA-PRO, and a PROM for glucocorticoid impact, the steroid-PRO. So looking forward to your talk, and the screen is yours, Jo. I'm not seeing nor hearing you at the moment, Jo.
Hi, can you hear me? I'm just going to try and
Yes.
share it again. Otherwise, we might have to go to the follow-up of it being shared, I think.
We hear you loud and clear.
Brilliant. And so, can you see that from on full screen version?
Not yet.
Is that sharing at all?
Yes, it is, for sure.
But it's
But
on
not
the small
yet.
bit.
Yes, not yet in full screen mode.
Okay. I don't know if Celine, did you want to stop sharing because we've had an issue with this? Yeah, I think we might have to move to it being shared on your end, please. Celine, do you have the presentation? And then I can just say for you to move on.
Would it in the meantime be possible for you, Jo, to turn on your camera?
Yeah, sorry.
No problem.
Right, there we go.
Yes.
I'm so sorry about that. We
There
did
we
have a
go.
test yesterday, but it seemed to have gone wrong in the meantime. So again, thank you so much for allowing me to talk about PROMs. I've been asked to talk about fatigue, actually, particularly, and patient-reported outcome measures. And brilliant to follow Julie to give the patient's perspective. So could you move on the slide, please? Brilliant. These are just my conflicts of interest, which we talked about before. Next slide, please. So yes, I'm going to talk mainly about fatigue to start with. What do we know about it in vasculitis? What can we learn from other inflammatory conditions? And what can we actually do about it? Next slide, please. So we know that we've done quite a lot of patient reported outcomes, and we've done lots of qualitative research with patients, both our group and also investigators in the US and Australia as well. And we can see here some of the patient quotes showing just how all-encompassing fatigue is. So it's actually rated as of having higher impacts than some kind of clinical outcomes like being on dialysis or having sort of nerve pain from peripheral neuropathy, for example, when patients are asked to rank what's the most important sort of areas of impact to them. And really it's regardless of gender or age. It can impact on sleep or work, family life. And it's very, very much physical, but also a mental impact of fatigue, which can affect all different ranges of aspects of life. Next slide, please. So we know that health-related quality of life is impaired in ANCA-associated vasculitis, and sort of threading the PROMs throughout this presentation. The SF36 is a generic measure of health status, and it's really excellent in that you can use it to compare between different disease controls, general population controls, and also obviously within trials, etc. as well. So it has a number of different domains, and in terms of looking at fatigue, we commonly use the vitality domain, shown here down the bottom, and this is a nice questionnaire-based survey performed by Neil Basu back in 2014, which looked to compare patients with disease controls and general population. And you can see from this figure that all of the different domains are impacted, but very significantly the vitality domain, particularly so in AAV. Next slide, please. So looking at the longitudinal course of fatigue in AAV, so some authors were able to look at the 18-month follow-up of almost 150 patients from the RITUXVAS and the MyPsych trials. And in this, they actually chose to measure fatigue at baseline and then every 6 months using the vitality domain and compare it to controls. So they took matched patients who did not have vasculitis at all to compare with. Very interestingly, they used a group-based trajectory modelling to determine the trajectory of this symptom and try and look at different baseline characteristics and what could be sort of associated with fatigue scores improving or not. So across the board, fatigue was worse at baseline in AAV and follow-up than controls, but there were some improvements over 6 months. Interestingly, there are different patterns of fatigue. So this is not fatigue happens in one particular way in everybody with AAV. It's very different and very individual. So if we move on to the next slide. So this shows the trajectory of 4 different groups which the authors were able to identify. Some patients had stable high fatigue, which meant that they had high fatigue throughout the whole course of the 18 months. So these were patients in obviously an interventional trial. So you would have expected that generally their disease activity should have improved. Some patients had very low levels of fatigue, which were very comparable to the normal population. Then there are 2 other categories of patients, some who had high fatigue, which got better, and some who had sort of moderate fatigue that got better. So the authors then wanted to try and identify, well, what were the difference between these groups? Were there any difference in demographics or in terms of the disease features? And they looked at a variety of range in terms of, sort of gender and age, etc. And the only thing that could differentiate was that the stably high fatigue group, the ones which didn't change, had a lower BVAS score at diagnosis. There was no difference in relapse rate, CRP or VDI. And it's not clear why people with a lower BVAS score at diagnosis actually had higher fatigue scores at all, and that stayed the same. But it does show that there's likely to be a lot of multifactorial aspects to this, and there's not one thing which is related to potentially having high inflammation, for example. Some people do improve with treatment, but some definitely do not. Next slide, please. So this again goes back to the questionnaire study performed by Neil Basu in another one in 2013, and this looked at a variety of different patient-reported outcome measures related to sleep. They asked demographic features, some clinical features like CRP, and also some different coping strategy questionnaires as well. And they found, in terms of what were the associations with fatigue, this was again very multifactorial. Obviously things such as sleep disturbance, and we might wonder definitely about the impact of steroids in particularly our sort of traditional ways of treating people, but also coping styles and inflammation were all there in the mix. Actually, a recent review in the Expert Review of Clinical Immunology highlighted that there's likely to be some underpinning factors in fatigue across different diseases. So this systematic review looked at vasculitis, but also systemic sclerosis and chronic fatigue syndrome. And there's a suggestion that says immune and metabolic similarities, obviously not completely, but fatigue can persist throughout all of these conditions, and it's not usually fully related to either disease activity or progression of the disease itself. So it is more complex. Next slide, please. So helpfully in 2023, there was a big initiative from EULAR to try and develop some recommendations on how we should be managing fatigue. So the authors highlighted that fatigue is very prevalent in people with inflammatory, rheumatic and musculoskeletal diseases, and it's one of the most challenging symptoms to manage in clinic. There are multiple factors associated with driving it and maintaining fatigue, so you do need quite a thoughtful, multifaceted approach to its management. So helpfully these recommendations were based on very in-depth systematic reviews of both non-pharmacological and pharmacological interventions in people with inflammatory, rheumatic and musculoskeletal diseases. This did include all of our patients with vasculitis, so ankle-associated vasculitis and giant cell arteritis in terms of the search. But obviously I feel we're slightly further behind in some ways than other diseases such as rheumatoid arthritis, in that there weren't so many to report, but really interesting to have a look at. So next slide, please. So they came up with 4 different overarching principles, which definitely I think hold true for vasculitis as well, that we as a health professional should be aware that it's encompassing multiple and mutually interacting biological, psychological and social factors. So as Julie was saying, it's not just your disease activity, other things such as stress or pain or sleep or infections can all interact with your general health-related quality of life. We should be monitoring fatigue, so if you're not measuring it, you probably won't know about it. And I think because clinicians, sometimes we don't really have all the tools to address it, that can lead to patients feeling that this symptom is dismissed in the clinic because we can't immediately go, oh, we'll give you a drug to try and switch it off. But we should be thinking about it, monitoring it, and management options should be offered as part of clinical care. As you always highlight very rightly, that this should be a shared decision because between the person with the inflammatory rheumatic disease and professionals, and it should be based on the needs and preferences of people, as well as considering their overall picture like clinical disease activity, etc., and contextual factors. Next slide, please. So here are the recommendations. So the first one is that we should be regularly assessing this, which I don't think we're great at doing in clinical practice, but so one to think about. We should be offering people with inflammatory rheumatic disease kind of tailored physical activity interventions, and we should be encouraging them to engage in long-term physical activity. As part of their care, people should be offered some psychoeducational interventions as well. So commonly the literature in rheumatoid arthritis, for example, highlights that there's a lot of fear around kind of taking part in physical activity, and even though these interventions have been shown to be beneficial, people are understandably, if they're fatigued and in pain, it can be a lot of barriers to taking part. And we have looked at this in terms of opinions on physical activities in GCA in the UK and the USA before, and that was definitely some barriers there. The last one is that the presence of worsening fatigue should trigger, however, evaluation of inflammatory disease and consider immunomodulatory treatment if needed. So that's not to say that this isn't all, sometimes it is due to the inflammation, so we always have to bear that in mind. Next slide, please. So here is the meta-analysis of the non-pharmacological RCTs. So this is things such as physical activity, psychological or educational interventions, a combination of both of those, follow-up models and consultations. And you'll see here that there's none of these relate to vasculitis. They were all put into the search criteria, but there's none which met the level of an RCT. But there is RCT evidence in these other inflammatory diseases, which I feel are very similar diseases in terms of the inflammation load and the fatigue load, so we can definitely learn from them. I would say that the development of interventions and the testing of them is incredibly rigorous, and you really need to have like a methodological approach with methodologists in sort of physical activity, behavioural science, etc. So it's one to really kind of consider quite carefully, but definitely a big gap, I think, in vasculitis. Next slide, please. Next slide, please. Thank you. So the one that has been done so far is Lorraine Harper's group in Birmingham, who did an excellent physical activity and behavioural change in vasculitis feasibility study. So as I was mentioning, there's various different studies, various different stages for the development of physical activity and sort of psychological behavioural change trials. And the first one is that you have to make sure that they're feasible. So this is a whole massive study in itself with stop-go criteria in terms of, are you recruiting people? Are people adhering to it? So the biggest thing is, like we'll all know, you start a physical activity program and then after like a month or so you kind of drift off and life gets busy or very hard to fit in. So the adherence side of it and completing the intervention is a barrier, because it is something that people have to go to. And you have to have a think about the interventions being kind of robust enough to actually create a reaction, create an impact and actually change outcomes, but not too intrusive or intensive that people won't want to sign up for it, basically. So I think there's always that tension. So this showed that a qualitative result showed that the intervention was acceptable, but there was sort of 50% of people who completed the intervention as per the intended schedule. So next slide, please. So the take-home messages really were that this does seem to be something that vasculitis patients can be recruited to, which is brilliant. And there's definitely no recommended therapies to treat fatigue, but physical activity may genuinely help. But we need a large RCT to really assess the clinical benefits. So because it was a feasibility study, we didn't have the data on whether it clinically benefited people, but the quali kind of feedback was very positive. And also then on ongoing things like the cost effectiveness has to be considered as well. So it's like methodological input required at every different stage of these kind of studies. Also, from my point of view, I think maybe we should be considering interventions with people across a broader range of rare autoimmune inflammatory conditions. So as Julie said, I do think there's something different comparing rheumatoid arthritis and people with vasculitis or lupus, because you've got that rarity, you've got that sense of isolation and that complexity that people come across in all aspects of their lives, from doctors and specialists, GPs, and also family and friends. So something bringing people together may make it more feasible as well in terms of the economic side of things within the NHS, for example, as well as being a benefit to patients. But that's all work in progress. Next slide, please. So now here's the meta-analysis of the pharmacological interventions from the EULAR study. So as you see here, these all again are not in vasculitis, because it was again, this is the meta-analysis of more than one RCT. But next slide here, next slide please. But we do actually have one RCT, which has shown that there was a reduction in fatigue with a treatment, which is brilliant. So next slide please. So this is obviously the GIACTA study. There was a second paper that followed up from the initial one, looking specifically at health-related quality of life. So here we can see that patients with GCA who receive tocilizumab and PRED over 26 weeks, there was a statistically significant and a clinically meaningful improvement in both the SF36 and the FACIT fatigue scores compared with prednisolone alone on its own. And actually there was a recovery of health-related quality of life, at least comparable to those of age and gender matched normative values at week 52, which is obviously, I remember this coming out and being really quite exciting. I think it's definitely showing a benefit of biological therapy in patients, and obviously this is a large RCT, so that's excellent. But is the only one so far that has shown that, and that was just in giant cell arteritis. Next slide, please. So we've also had a very similar project as a sort of a post hoc analysis looking at the advocate, i.e. the Avacopan trial, and that was by a similar team. And they looked to see again whether there was improvements in SF36. So what they could say from this was that the proportion of patients reported scores equal or greater than the normative values was higher in the Avacopan group than in the prednisolone group across all SF36 domains at both week 26 and 52. But the only domains that were actually statistically significant were role physical and the vitality. So again, the vitality one is the fatigue one at week 26. Next slide, please. So the discussion within that paper and just generally around this point about treating sort of fatigue with immunomodulatory treatments. This is the first time an RCT in AAV has actually shown a benefit in terms of health-related quality of life. And the discussion is thoughtfully kind of discussed as whether this could be effective having less steroids, which we know do impact on quality of life. But in other trials, such as Pexavas or Lovas, they didn't see that benefit. So it does raise the question of whether the direct effect of the C5 inhibition itself is actually improving the fatigue, but obviously more studies are needed. They also mentioned that a disease-specific probe may potentially demonstrate greater differences between arms, and this is because it's designed to be more relevant to the disease in question. Next slide, please. So this sort of leads us on to our disease-specific patient-reported outcome measures. Next slide, please. So I want to focus firstly on the AAV Pro and give you an update on how it could be used in an RCT and other studies. So this was published back in 2018. It's a disease-specific Pro based on 50 interviews with patients with GPA, MPA and EGPA. And those interviews were used to develop items specific to the patient perception of different both sort of features clinically and also impact on health-related quality of life. We then used a survey using rash and factor analysis to identify a shorter list of items which fit into 6 different domains. So it's a bit like the SF36 in terms of it's got different domains within it. And these are organ-specific symptoms. So here, oh yes, we moved on to here. So looking at these different organ domains, so particularly want to highlight the organ-specific symptoms at the top left. So these were, and the rash and the factor analysis links the two, identified which items naturally fit together to form a domain. So these ones very much from a clinical point of view, we would recognise as those related to more limited, potentially kind of relapsing disease, PR3 positive, things like nose or sinus problems, problems with the ears, chest problems, problems with the mouth or throat, and problems with the eyes. The systemic symptoms really fit together with what we might consider to be more of the fatigue side of things, the vitality kind of domain in the SF36, like the aching, tiredness or fatigue. We then have some sort of social and emotional type domains with the social and emotional impact and concerns about the future. And then we have physical function, which again is about walking around, doing things physically that you want to do, and also some ADLs. And treatment side effects, which is actually looking at it now, because we obviously produced this back in 2018, is really highlighting steroid impact a lot, which is really the key aspect that people were kind of really highlighting in the interviews and through the rash, etc. Next slide, please. So very recently accepted for publication is this European EGPA study group project, which is looking at a cohort of patients who had refractory or relapsing disease with EGPA, who were all starting mepolizumab, and following the AAV Pro and also a patient VAS at baseline, and then over 7, 14, 30, 90 and 180 days. So the patients were mainly 70 patients, and 50% were female with a usual sort of median age, and all had relapsing and refractory course. So they were all patients who you would be considering to add in mepolizumab at that stage, but it's a multi-centre cohort. Next slide, please. So this is really exciting to me because it's the first time we've actually used the AAV Pro in a cohort of patients where they had very high disease activity, and to show the change and the ability of the AAV Pro to actually detect change. So across all of the different 6 domains, there was this big change, obviously, in the graph. So I'm focusing in on the organ-specific symptoms because this is the one that came out at 6 months as the greatest change. Actually, by 14 days, all the AAV Pro domains, except the treatment side effects, which is related to steroids, showed a statistically significant decline, i.e. an improvement in health-related quality of life. And if you can look on the left-hand side with the graph here, if you look at the bottom, it's actually quite small, but within the 30 days is the area of the greatest change. So it's really quick at picking up change. Patient VAS did also pick up change by 7 days, I have to say, but obviously it's less specific to AAV. And obviously we only have one arm here. This is just looking at all patients who have started mepolizumab, but it's a really nice way of showing that the changes in these scores, as well as being very specific to AAV patients because of all the qualitative work and the rash analysis, they do actually work as a measurement over time in people experiencing a change in their disease state. So I'm very pleased to see that. So thank you very much to the European EGPA group for doing that. Next slide, please. Also, obviously, we've had a really nice study in Germany in patients who were in their German cohort, 150 patients, and this was a prospective longitudinal study. And this, the strengths of this study was that they looked at lots of other different quality of life, patient-reported outcome measures, and also looked at some associations with BVAS and VDI. So again, the mean BVAS score, because they're all very well controlled in this cohort, which is brilliant, but it's showing the activity levels of this study were quite low at 1.4, so they're all nicely, reasonably low control. They weren't too active. But despite this, the AAV Pro scores in those people reporting high activity versus in remission did show a known groups change between the two groups. But there's no association between the AAV Pro scores and the BVAS or VDI, which we've shown before in other studies, i.e. it's a different measure compared with the clinician measurements. And in the correlation analysis, all of the AAV Pro scores were strongly correlated with either the BDI or the SF36 domains. Next slide, please. And here they've done some regression analysis of looking at the AAV Pro domain. So again, on the left with the organ-specific symptoms of the AAV Pro, this is strongly related to, well, this is associated with relapses, which we're thinking of more ENT, lung involvement, eye involvement, etc. We know that that clinically does occur, and pain. And also the systemic symptom severity scale is, interestingly, in the regression analysis, the SF36 or energy or fatigue one came out as well. And the other ones, as kind of, as you can see, were associated with more of the emotional well-being and the depression aspects as well with the BDI. Next slide, please. And this is looking at a comparison of some of the AAV Pro studies, which is where you can just start to try and use the AAV Pro in sort of observational studies to kind of pull out different impacts on different patients who might therefore need further support, for example, or targeting and interventions. So women do tend to score worse on all the AAV Pro domains. All of the items were developed to be equally relevant to men and women very specifically, and they were developed to be equally relevant to different age groups. For example, you won't get anything about only a work within one question or only school within one question. They were designed to actually be useful and relevant to people of any stage in their life. And there's also some correlations with other different things. These other studies were all in quite very well controlled cohorts. So the BVAS was all quite low. So that's what I think the recent mepolizumab study showing that really big change in state is brilliant, because that's the first one that shows that change can be picked up with the AAV Pro and within the first 14 days as well. Next slide, please. So lastly, I just want to very briefly touch on the GCA Pro, which is one that we've published more recently, and again based on sort of FDA methodology for the development of PROMs, and with lots of patient input at every stage. It's been translated into 7 languages and is being out there, being put into different studies and things at the moment. So that's very exciting. Next slide, please. And the Steroid Pro. So we've developed this, and again, looking broadly beyond vasculitis, so also in inflammatory arthritis, GCA, connective tissue disease such as lupus and vasculitis. We've done the same process to develop a Steroid Pro, which is 1 page. It has 4 domains: impact on appearance, participation, treatment concerns, and direct psychological impact. And we've gone on to test that for feasibility and acceptability outside of sort of rheumatic conditions in people with inflammatory lung, bowel and skin conditions in the UK and USA. So again, that's just at the beginning. If people are kind of interested to try and use this or test that out for us, that'd be fantastic. Next slide, please. And going back to the patient point of view again, from that Steroid Pro work, something really nice that's come out of it is looking at the impact of glucocorticoids on appearance and sense of self. So this has really come out as a really strong and important aspect across all of the inflammatory diseases. There's the societal norms that we all live within, patients reporting pressure to conform to that, and that can vary depending on cultural background. But generally, people saying, you don't think anyone likes putting on weight, and there's a part of you thinks that, thin is better, etc. All that pressure, people were describing as making people feel that they didn't feel like themselves. And this could interact with change in mood. Obviously, we know that steroids impact your mood and your sleep as well. And also a massive burden of adjustments, particularly in the kind of current cost of living crisis, in terms of needing to make time for exercise, changing diet, possibly working at home, reduction in hobbies. And a lot of these do carry cost implications, which we should consider as well. Next slide, please. I think that's it. So thank you very much for moving on the slides. And I think that's my section. So whether we open up to questions with Julie as well.
Thank you very much for your presentation, Jo. Indeed, we will go now. We are now open for questions. So please do put your question down at the Q&A. And while we are waiting for questions to come in, I would like to ask a few questions. So my first question would be to Julie. We have heard a lot about your experience, and I was wondering, can you tell us a little bit more about how you experienced fatigue and what were the things that could help you managing this?
Fatigue. I think, for somebody that hasn't experienced it, we all think fatigue as tiredness. But whenever I got vasculitis and I experienced fatigue for the first time, I thought, oh my God, I feel like I've run onto the back of a bus. It's just so overwhelming. It's very hard to describe it. You just don't function when you have really severe fatigue. And the funny thing was, I used to be an occupational therapist, so I would have done like fatigue management with my patients. Um, so I suppose in a way I was lucky in that I kind of knew some of the things to do. So things like watching my energy levels, um, prioritizing what I wanted to do. But I think Jo had touched on it there about the fact that because it's fatigue doesn't mean that you shouldn't push yourself physically. But I think you have to do it in a measured way. And pushing yourself that little bit physically, like doing a little bit of daily exercise, can increase your stamina. So then that kind of reduces your fatigue a little bit more. I think the other thing about fatigue is the psychological aspect of it, the psychological side of it, um, because you just feel so overwhelmed and useless. And it's very hard to explain that to people, and it's very hard for them to understand it as well. Um, but, like maybe kind of taking it yourself and taking, like measuring how you're managing it, making sure you don't overdo things when you do feel well. Like I know whenever we're on steroids and when we go on to a higher dose and things are working, then all of a sudden you're like a Duracell bunny. And then you just hit this fatigue wall then because you've overdone things because you felt good. So you just need to be very mindful of those things. Just it's a constant, but it is you can manage it. You can manage it. I don't know,
Thank you
Jo, do
very
you add any more to that or?
No, I think that's a really good illustration, like the physical and mental, just the brick wall, and how it's not
Mm,
just feeling tired, it's just overwhelming, isn't it? And I think there's lots more work to be done in this area, definitely for vasculitis, and
yeah, yeah.
definitely, yeah.
So I would like to ask you a few questions that have come up. Cecile Armstrong is asking Julie, what can patient organizations do to promote improvement of quality of life? And she gives some examples like meetups and coffee and chat, exercise. What's your view on that? What patient organizations can do?
I think patient organisations have a really important role. I think, I suppose, for some people coming into a patient organisation, you feel like, oh, I'm going to have to share everything, and like you're going to be in a situation that you feel uncomfortable in. But I think being able to talk to other people that have lived or are living with the same experience, we can learn so much from each other. Um, the the relief that you have when you're talking to somebody else that's living with vasculitis is enormous because you don't have to keep constantly explaining, oh well, I couldn't go out because like I was fatigued, and like, and explaining things all the time, or explaining treatments, or explaining, your illness. You don't have to do that with people that are the same as you. You could just have a normal conversation. It's really good for your well-being. People are very respectful of your journey. Everybody's journey is very different. But I think with COVID, in one way, it was a good thing for us that we went online for our meetings, because before that we would be organising meetings all over Ireland at that stage, and there wouldn't be a big attendance at the meetings, and that's not because of lack of interest. It's because it's difficult for people to travel, or they may not have been feeling well on that day, or they may have thought, oh, it'll be a wee bit awkward coming and meeting strangers. But when we went online, it was so much easier, and if people were feeling a little bit uncomfortable, it was fine. They could have their camera off if they wanted. They can input where they want, where they don't want, that type of thing. We would have coffee and chat. We have online coffee and chat. We have in-person coffee and chat. And then we like to try and have the odd in-person meeting, which is always, it always strikes me that we put a lot of effort into organising speakers and information to be there. But if we just said, right, we're going to have lunch, I think you could fill a full day just with people talking to each other, so yeah.
Thank you. Thank you for your answer to that questions. So I now have a few questions for Jo. The first one is from Bram Rutgers, and he is asking what your take is on the glucocorticoid toxicity index in relation to the steroid pro. And the question is, could the steroid pro replace this GTI?
Yeah, so obviously the GTI has been used in lots of trials, and it's helpful to sort of conceptualize it. That's a clinically based, it's called a clin pro, I think. So it's a clinically based, it's completed by the clinician about different items which are really important and very well established. So the steroid pro is different in that it's kind of capturing things from the patient's point of view. So they're definitely complementary. So I know there has been some studies which are underway looking at them in comparison. I think that'd be interesting. I kind of tend to see it a bit like the AAV pro is about patient impact and the BVAS is about activity and the VDI is damage. So obviously it's a similar kind of thing that they're looking at different constructs, and hopefully at some stage there'll be a project where we can look at them together and see whether that explains like the whole impact to the person clinically, and from there kind of some of the things which are more psychologically based, for example, which I think there's a completely different role for different things really. So yeah.
And another question on the PROMs is, so you have already mentioned that the AAV Pro has been translated to many different languages, and I believe the GCA has also been translated, but there is a specific question on the Steroid Pro that has recently been developed. If it would be available to use in other countries, other languages, and how we could make this work.
Oh yeah, so there's the first translation is just underway into German at the moment, but so it's very early on. So if people are interested in helping us translate it, then do get in contact with me. I'm definitely in testing it out in different contexts. As I've seen, sort of tried to show the AAV Pro, it's good to put it into different contexts, and then you can learn more about how the Pro is working. So yeah, very, very keen to get it out there really and collaborate on things. So.
And more question for myself is, how do you see us implementing the pros in daily clinical practice? Because I think now for the AAV Pro, we already have a lot of data on it that it's very useful, but how can we implement it in clinical practice? What steps should be taken?
Yeah, so again, that's a whole other methodological kind of question in terms of incorporating PROMs. Obviously, in clinical trials, it's easier in a way because you normally have an iPad and people it's part of the RCT kind of structure. But in clinical practice, that's something that we're actively looking into in the UK in terms of trying to build it into our computer systems, and they're very different in different parts of the UK, for example. Trying to set, ideally sending PROMs to people before they attend clinic, how this might impact on shared decision making, which is like a priority for you, obviously, and where that might kind of point you in the direction, like if you had if, for example, the AOV Pro, if it showed that you had a lot of fatigue or that kind of thing, then maybe more fatigue management, but we've got to develop and make sure that that's all validated. Or if it's about kind of low mood, maybe other support or informational needs. So yes, I think there's loads of different stuff to explore and develop in that. So yeah, really keen to collaborate on anyone who's got some good ideas about that. I think that's the next step for clinical practice, because hopefully it will be useful, definitely.
And there's a question coming in on if any of the two of you is aware of any patients with vasculitis who tried vagal nerve stimulation to treat fatigue. Is this something?
Yeah, so I've seen presentations on this in other rheumatic conditions, but I haven't looked at the literature for it. I think it may have been included in the systematic review actually in EUVAS, but I don't think it met the level, but it may have been included in the narrative review. But I couldn't say off the top of my head. But it is something that was out there, but hasn't been widely taken up from my understanding. Interesting though.
Yeah.
There are many. Oh, okay. No, you haven't, Julie? Heard about this?
No.
Is there anything you would like to add, Julie, about the implementation of PROMs from your point of view?
I think this is the way forward, really. I think this is the missing link that we have in learning more about vasculitis. I would be very keen for us to start getting PROMs as a way of life and as like an accepted thing that happens whenever either you go to the clinic or in preparation for going to the clinic. At the moment, we're exploring being able to have an app. There's an awful lot of apps out there at the moment, and it's very hard to, I suppose, to tie up all the information. So there's lots of little silos of information being gathered, and it would be lovely to have somewhere that we would be able to gather it all in one place for vasculitis. Like, this is my pipe dream, that we would have
A good dream. Yes.
one place that would have all these PROMs, and then that we can use that then, like alongside the registries and the biobanks. And I think we would learn so much. I think the other thing, like as well as for healthcare team members and that learning about the vasculitis, I think patients actually doing PROMs and filling them out, they learn an awful lot about their condition themselves. There's nothing like putting it down on paper to kind of start recognizing, oh gosh, I've noticed there, like my step count went down there, or I wasn't as active there, and that was whenever I was coming into that infection, or we could learn a lot more ourselves about managing our condition. Sorry, Jo, I don't know.
Okay, thank you so much. So looking at the time, we have now reached the end of today's webinar. On behalf of the ERN-RITA and EUVAS, we would like to thank, of course, our two speakers, Julie and Jo, for their excellent contribution and, of course, the discussion that followed. Thank you, everyone who joined us for this Tuesday lunch with RITA and EUVAS session. So it's organized as part of the Vasculitis Awareness Month. Before you leave, please do fill in our short survey about your feedback that will appear when the webinar is closed. And we hope to see you again in 2 weeks, May 27th, for the next and last webinar of this special series in this Vasculitis Awareness Month. Thank you very much for attending.